Greetings, everyone. Today, I'm truly honored because I have someone with me who has inspired me a lot in the journey of psychiatry. Uh, I have someone whose passion for psychiatry is almost as deep as his passion for philosophy. He is a clinical assistant professor at Case Western University in Cleveland. He's an author. He has a blog with over almost 14,000 subscriptions, which is unheard of for psychiatry or any, I would say, educational field. Uh, he has written books, and recently his book was published by Oxford University Publishers. Uh, I have known him for many years. I have never met him, I must say, but I have known him many years. We share a mentor, Dr. Ali Hashmi, as well. So without further ado, let me invite Dr. Awais Aftab. Thank you, Dr. Aftab, for joining us.
Thank you, Emma. Thanks for having me. And it's great to chat with you today.
Absolutely, absolutely. And again, my wife, I think, is a couple of years junior from you in King Edward, and everyone knew in King Edward about you that your passion for philosophy. And it intrigued me because I don't see a lot of people. I have met over the years a few people that are really interested in philosophy, spirituality, in addition to psychiatry. But tell me a little bit about it. Seems like that you picked that interest pretty early in your even like age, during even childhood. Tell us a little bit about
Yeah, so I've had a interest in philosophy for a very long time now. It started around the time I was finishing my O levels in Pakistan,
that.
and when I and it really flourished when I went into college, studying
Okay.
pre-medicine in Pakistan. And it got to a point where I was even seriously contemplating, should I go into academic philosophy as a career? Should I kind of, kind of make that decision and pivot towards that? But as you're well aware too, in Pakistan, it's just not a viable career option, and there were a lot of physicians in my family, and medicine just ended up, seemed like a more natural kind of choice. And I think in retrospect, I'm kind of glad that I went into medicine and I became a psychiatrist because I love clinical work and I kind of love the kind of problems that I help patients address. And there's this thriving intersection between philosophy and psychiatry. So I'm very happy with what I'm doing. But originally, there was a point in my life, in kind of teenage years, when I was passionate enough about philosophy that I was thinking, hey, should I do this, professionally? I kept up with that interest during my medical school. So I kept reading philosophical literature, especially kind of including, philosophical literature as it relates to psychiatry and psychology. And then as I started my psychiatry residency in US, I became more devoted to studying the philosophical aspects of psychiatry, and I read the kind of like the academic literature that had been
Mhm.
published. And I was fortunate that I discovered that there's a very strong and flourishing interdisciplinary community of people devoted to the study of philosophy of psychiatry. And one of the main associations in North America is called Association for the Advancement of Philosophy and Psychiatry, AAPP. And they have an annual meeting, and its members include psychiatrists as well as philosophers,
Mhm.
psychologists. And these meetings are often attended by other academics like historians, anthropologists, sociologists, etc. And so even though I don't have a formal
Mhm.
philosophy training, I don't have a philosophy degree, I
Mhm.
feel fortunate that I was able to learn enough philosophy on my own that I was able to contribute to these debates that were happening in the field, and I was able
Absolutely.
to contribute to the discipline.
Okay. And with that, my question is that how has your background in philosophy shaped your clinical practice?
The biggest thing for me, I think, is that my interest in philosophy has led me to pay more attention to hidden assumptions that guide clinical work, that guide clinical assessment, and that shape how we think about patients and how we think about disordered states. And so being aware of those hidden or implicit assumptions and questioning them and kind of thinking about perhaps better ways of reframing, re-examining those issues has been the biggest thing. So my own, for example, in the early days, my a big focus of my philosophical interest in psychiatry was the nature of disorder judgments. That when we say that a behavior or an experience is disordered in the psychological behavior, and what exactly do we mean? What kind of judgment is that? What factors are involved in that? And so I spent years, and I still do. I still think about this question, but in the beginning, I spent years kind of thinking intensely about what is going on here, trying to understand how when when I'm offering a diagnosis in the clinic, what is happening behind the scene, and how does that relate to the kinds of philosophical discussions that have taken place. So awareness of, I think, assumptions has been an important part. That has also, I think, influenced how I talk to patients and how I interact with patients. I think a lot of the terms that we use, their meaning is not apparent, to clinicians or patients. If you tell a patient, you have anxiety and your anxiety is a medical disorder or your anxiety is a disease, the patient is likely to leave with a very different kind of idea or understanding of what that means, compared to, what a conceptually correct understanding might be. And I think because we have relied on these loaded, heavy terms, and we have not made the assumptions very clear, it has generated a kind of polarized debate around psychiatry.
Absolutely,
Where
yeah.
there are, I think, there's a reductionistic kind of camp within the profession that understands these diagnoses in terms of brain dysfunctions and kind of brain abnormalities, versus the kind of there are others who understand it in behavioral terms, kind of evaluated in terms, and then there's the kind of public who is kind of caught in the middle and doesn't know how to what exactly to do about it. So my own, as I have engaged with debates and controversies around psychiatry, I've realized that a lot of them are kind of downstream products of being conceptually confused about what is going on when in the process of diagnosis and treatment.
No, and you're definitely so, especially your blogs that you write, your Twitter posts now called as X, and especially I think I tend to write some of those things as well. Of course, not at that level, but I think there's a huge community out there. The what we call the anti-psychiatry group, of course, started by Thomas Szasz back in really 70s. Now, I have seen that you have interacted with some of those folks on Twitter at some forums, and what I have found different in your writing is that the way you answer them is significantly different than a clinical psychiatrist like me would answer, because maybe I come from a different perspective. But the way I think that there was a recent a UK based psychiatrist, I think she had an interview, and then there was all a controversy about questioning the legitimacy of psychiatric diagnoses, psychiatric medications, long debate about SSRIs. So I would ask you what's your perspective on overall anti-psychiatry as a term, as a group of people, and how you navigate that discussion, especially with your patients.
Yeah. So I think anti-psychiatry is another one of those big, complicated debates that can easily generate a lot of confusion, because the term means different things. It refers to different kind of, individuals, different kinds of critics. And there are different aspects to it. So on my blog, for example, Substack, Psychiatry at the Margin, I've explored this phenomena or in several different posts, trying to understand it from different perspectives. And it's important to understand different dimensions of it. So, for example, historically speaking, we often talk about anti-psychiatry as this very fierce academic critique of psychiatry that emerged in the 1960s. And this revolved around a group of individuals whose writings provided the philosophical and intellectual force. So there was Thomas Szasz in the U.S., a psychiatrist himself with somewhat kind of unconventional, interesting opinions. His book Myth of Mental Illness came out in 1961. In the British side, on the UK side, there was the psychiatrist R.D. Laing. And his book, The Divide Itself, came out around 1960 as well, which was an existential analysis of schizophrenia and psychotic states. And then the French philosopher Michel Foucault, he presented a historical and sociological account of mental illness and how notions of mental illness were shaped by notions of enlightenment. And then Irving Goffman in the US, it was kind of a sociological analysis of asylums. So they generated this intense critique, and what they had in common was that they were, I think, challenging many ideas that were taken for granted in the medical psychiatry at that time about nature of disease, etc. And they were also, I think, concerned about the way the emerging medical psychiatry was perhaps silencing or ignoring or misunderstanding the phenomenological and kind of meaningful aspects of serious mental illness. That psychosis is not a meaningless state, but rather it interacts with the person's life history, it interacts with the person's context. And also they were worried about the increasing social power that this kind of these kind of disorder judgments had. Remember in the 1960s, homosexuality was still considered a psychiatric disorder, still a pathology. Michel Foucault himself was a homosexual. So you can see how some of those things would color their relationship with psychiatry. 1960 was also a time of kind of rise of civil rights, and all kinds of authorities were under challenge, and that was still the asylum era as well. And we know the kind of the track record of clinical care in the asylum era was not that great. So there were many legitimate reasons, kind of both I think practical, clinical, as well as philosophical. So there has been that academic critique. And then there are many, I think, philosophers and psychiatrists themselves who have continued on that tradition of intellectual critique and who are still working with some of those same ideas. The problem is that many of the central arguments, especially from Thomas Szasz, had fundamental philosophical issues or problems with them. Szasz believed that he had a very reductive idea of what constitutes disease or disorder. For something to be disorder or illness for Szasz, there had to be a demonstrable anatomical or physiological abnormality. And if you didn't have that, if there wasn't a biological abnormality, then the condition was just a problem in living. It was just behavioral deviance, and it wasn't a condition that belonged in medicine. And that prompted huge philosophical debates in the field about what is disorder and what is illness, and people develop more productive philosophical accounts of that. But there are still psychiatrists who for example believe Szasz's ideas and take that ideas to be granted. Another thing that happened, I think, in the last 20, 30 years, even longer, is that the social media, I think, provided a platform for a lot of people who were dissatisfied with psychiatry to kind of come together and exchange intellectual ideas, and they started using internet as a platform for advocacy. And so we saw a merger of these kinds of intellectual critiques of psychiatry with these kind of more on the ground kind of activist critiques of of psychiatry. And due to the pharmacological revolution and increased diagnosis and increased treatment, we also have large numbers of people who have had serious negative experiences with psychiatry. So they have had adverse effects with medications, or they have had terrible experiences with, involuntary psychiatric care, for example. So we also have, the quote unquote harmed patient community whose animosity towards psychiatry comes from their own negative experiences. So they are also kind of, involved in this kind of state. So the end result is that, especially online and many other parts of the kind of internet, psychiatry is under fierce critique and under fierce hostility. And there are kind of, there are some biased kind of, views about psychiatry, and there are exaggerations and kind of stereotypical. But there are also aspects of it that relate to genuine kind of meaningful philosophical questions, that relate to genuine kind of, scientific questions and scientific debates, genuine clinical questions about iatrogenic harm and how to navigate that. So it's been, I found it hard to dismiss the criticisms of psychiatry in kind of entirety, and in brushstrokes. So over the years, I've made a lot of effort in trying to engage with people who have been offering criticisms, and in trying to figure out kind of what kinds of criticisms, what kinds of arguments in debate hold some kind of value and meaning, things that the mainstream of the profession needs to pay attention to, versus to what extent is this animosity or is this hostility based on reasons unrelated to that, or based on erroneous understandings, etc. So when I engage with the quote unquote anti-psychiatry faction online, I try to keep it in mind. And I'm also, I think, I'm due to the history of that engagement, I'm sometimes a little better, a little more aware of the kinds of concerns that they have, or the kinds of philosophical or scientific questions they have in mind, that can be a little bit obscure to an average clinical psychiatrist. But at the same time, there some people are just so angry and so hostile that there is just no having a reasonable conversation or argument with them. So I have to pick my battles and see where it makes sense to engage and where it makes sense to ignore.
Absolutely. And I think that for medical students, the residents who are starting their residency, especially, I sometimes have discussion with them, and they share concerns about when they, of course, online, they read these things like anti-psychiatry. I think the biggest question they have in their mind, of course, once we all believe the serotonin pathway, and that was also something that proved out to be wrong. And even today, the anti-psych folks use that. So they use that it was wrong. Now, when they say that that was wrong, so what is the basis of psychiatric disorders when they are uh, questioning the legitimacy of it? So, what would be your answer to that? That how someone who's a medical student, who's even not a psychiatrist or even psychiatrist, should approach that when they are being asked those questions?
I think what happened. So one of the challenges with mental disorders and mental illness is that the suffering and incapacity can sometimes be hidden, and then sometimes be intangible. If someone is really anxious, someone is depressed, they're contemplating suicide, for example, someone has severe obsessions, even milder forms of psychotic disorders, the kind of another person cannot really peek into your mind and fully appreciate the severity of the suffering, impairment, and harm. So historically, we have seen a kind of difficulty in the public trying to understand the gravity of mental illness, or what is going on. What happened in the 1990s was that, in an effort to try to make that suffering more comprehensible to the public, and in order to facilitate the clinical and medical treatment of that suffering, the profession started relying on more concrete metaphors. So it started saying things like, oh, depression is a chemical imbalance, for example, or anxiety is a chemical imbalance. It started saying things like, mental disorders are brain diseases or they're bodily diseases, just like diabetes is a bodily disease. They started saying things like, antidepressants are medical treatments in the same way as insulin is a treatment for diabetes, right? So I think some of it was pharmaceutical marketing and advertisement, especially the chemical imbalance stuff. But a lot of the other ones, I think, terms like brain disorder, medical condition, analogies with diabetes, insulin, etc. They were, I think, well-intentioned efforts to try to make something that is abstract, something that is invisible, to try to communicate that, hey, this is a serious thing. This deserves clinical care. This deserves to be talked about openly. We should recognize this and we should treat it in the same kind of way as we treat physical health problems. But I think the profession didn't realize how loaded kind of, those buzzwords were and how they generated kind of false understanding of these things, a rather reductionistic understanding of these things in large numbers of people in the public, and also I think within the profession too. I think there was a lot of confusion, and understandably, kind of 90s were also the decade of the brain, so there was a lot of enthusiasm and optimism around emerging brain technologies and in kind of like, genetic studies. There was this kind of hope that we would find the, genes associated with mental illness and that we would find brain circuits associated with mental illness and kind of act on them. The story turned out to be much more complicated than that, and I think there weren't any simple neurotransmitter abnormalities. There aren't a few handful of genes associated with mental disorder, but rather hundreds and thousands, and they're all non-specific. And, so it turned out much more complicated. And it's also the case that mental disorders are not medical conditions in the same sense as neurological disorders are. They're not defined in terms of abnormalities of functioning of the nervous system, but rather they are defined in terms of behavioral disturbances. They're defined in terms of phenomenological and experiential features, which makes them inherently multi-level conditions and multi-level disorders, because we are navigating the psychological, cognitive, and the physiological kind of aspects of it. But all of that, I think, got neglected, and many people in the public got this distorted, simplistic idea, that it's been discovered that depression is fundamentally caused by a serotonin deficiency, serotonin abnormality, that antidepressants kind of work by fixing the level of those neurotransmitters, and et cetera, et cetera. And when I think the public started learning that the actual science is much more messy, that it's complicated, it's not quite as straightforward, I think many responded with a sense of betrayal. They felt that they had been lied to. They felt that they had been deceived. That they had been fed a false narrative, so that they would take medications, for example. And I think we're still dealing with the fallout of that sense of betrayal and anger. And I think what needs to happen is that I think the profession needs to, one, I think, openly acknowledge and be transparent about what happened. And I think the profession needs to be much more careful and mindful of how we are communicating issues about psychiatry and mental illness to the public, and what kind of language we're using and what kind of assumptions we have. I think if we engage in this kind of conceptual clarity and conceptual humility, I think our relationship with the public would improve.
Absolutely. And then I think what things that I see a lot, which a lot of people who do not believe in the legitimacy of psychiatry or mental health disorders. So there are a few buzzwords or statements I hear a lot. The one statement I hear a lot is everything is trauma. So trauma causes this, trauma causes that. And then sometimes the other statements like we hear is that we are pathologizing a normal human emotion like grief, sadness. So I think a few days ago someone wrote that pathologizing happiness into mania and sadness into depression. So, what's your opinion about statements like these, especially the trauma one? Because there's a lot of people. I mean, I have seen again really higher ups in those chains, psychiatrists, psychologists, that emphasizes a lot that. So basically, some of them think that trauma is at the center of everything.
Hmm. Yeah, I think I see the trauma thing. I see as a kind of opposite reaction to the biological reductionism of the 90s and early 2000s. So, as I mentioned, kind of what was happening in that era was that people were focused on trying to locate the source of these problems in kind of like in biology of the person. So they were trying to think that these are genetic conditions, like so they started thinking, oh, it's schizophrenia primarily caused by genetic abnormalities, or primarily things like depression, anxiety being primarily caused by dysfunctional brain circuits. So and that need to be regulated, or by other kinds of other physiological processes gone wrong or abnormal in some way. So the focus was very much on kind of internal etiology. And I think cognitive behavioral approaches and traditional psychodynamic one also emphasized the kind of like psychological process of the person, like what kind of cognitive distortions they're having, what unconscious conflict having. Um, so the social aspect of it was generally neglected at that time. And what happened was that due to the strong emphasis that was given on the so-called internal factors, the people who took the external factors seriously, they started, expressing the dissatisfaction and their opposition. So people who thought that early childhood adversity matters a great deal, that life stressors matter a big deal, that learning environment matters a great deal, they started kind of, and they started doing research work showing kind of how these things are important. There were, for example, like even studies showing how kind of trauma influences, serious mental illness like schizophrenia, so showing the associations between the two. And that, I think, movement over time, at least in the public imagination and in the imagination of many clinicians, started coalescing around the trauma narrative. So this idea that the causes of mental illness are primarily external became kind of associated with this buzzword that everything is trauma. So just as the people emphasizing genes and brain circuits and neurotransmitters had ignored the social aspects, the people who emerged, who started this in reaction, they wanna minimize and dismiss the internal factors as much as they can. So they try to deny that genes have any meaningful contribution to mental illness. They try to deny that there are any differences in brain circuits or differences in other kind of biological pathways, and everything becomes for them about the learning environment, the social environment, adverse life circumstances, etc. So I see that as just a kind of a thesis antithesis kind of unhelpful polarization that has developed. And if you look at the actual science, the actual science has disputed this kind of internal external causation for a very long time. Even from a genetics perspective, it's all the emphasis has been on gene environment interactions. Kind of on the kind of biology side, kind of we're recognizing how brain development is inherently linked with the early kind of like developmental environment, and how kind of all the environmental and social factors shape the development of the brain and functioning of the, so it's kind of like brain networks, etc. And also kind of philosophical approaches like inactivism and 4E cognition, they have dissolved this internal external causation, rather showing that there's tremendous feedback loops between the person and their environment that happen over time. And also complex dynamic systems. They treat the individual, the brain, as a complex system that is, interacting with the environment too. So the actual science has actually moved beyond this dichotomy of internal causes, external causes, but has been recognizing there's actually an interaction. There's an interaction between the person and their environment, and there are processes happening biologically and psychologically inside as well as, outside, and they're all interacting all the time. So while the scientists, I think, have been trying to engage, trying to figure out how do we talk about this kind of dynamic, how does a new complex system dynamic approach look like, or what does an inactive approach look like? I think the more pop version of it remains stuck in this dichotomy of trauma versus biology or genes versus biology, which is really frustrating and irritating to see that so many intelligent people, they cannot kind of, they're still they're stuck in an intellectual framework that belongs in the 20th century rather than the 21st century.
And I think someone wrote a tweet, I think that time, and that really stuck with me, that if people can realize that association and causation are different, we would be able to solve a lot of problems. And I think that person wrote in terms of trauma and psychiatric disorders, that there's a difference between causation and association.
Yes, yeah, sure. And I think there's a fundamentally speaking, there's a lack of, I think, scientific and epistemic humility. You see people online saying that, oh, we have figured out what the root causes of mental illness are. We haven't. No one knows what the root causes are. I mean, if we had, science, the state of science would be different. But we are recognizing it's all really complicated. It's all really messy, and it's all we have different factors at multiple levels of explanation interacting in these complex ways. So a root cause has become a buzzword, I think, and that is a red flag in my mind. I think anytime I see someone talk about root cause, whether it's metabolic or mitochondria or trauma or whatever, I tend to assign less credence to what they're saying. And then I want to go back to the second part of your question, which was about pathologization, which I think pathologization is another kind of philosophical buzzword that I think people use as a way of conveying disapproval. So what they're saying is that they don't like the fact that medicine is trying to treat something or medicine is trying to conceptualize something, because they have an inherently I think inherently reductive idea of what medicine is. They think that to call something a medical condition and to treat it means that you have to conceptualize it as a biological dysfunction, as an internal problem that is fixable, with some kind of a medical interaction. Versus, what is happening is that we are really interested in trying to recognize and address experiences of suffering and impairment and kind of and disability. That is the fundamental goal, and we're trying to kind of address those conditions which are limiting people's quality of life, which are causing negative emotional experiences that drive people to, for example, experience suicidality and other kind of unpleasant things that are socially disruptive, and we're trying to offer them tools they can use to do that. And medicine, the concepts of medicine are one way of looking at it and one way of treating it. Oftentimes they're quite remarkably effective. Sometimes they're, somewhat modestly effective. That doesn't mean that we cannot look at this suffering from other perspectives, other lenses, existential, spiritual, relational, etc. But I think so. People who bring up the pathologization argument, I think they have a fundamentally negative and reductive view of what medicine is trying to do. And so it becomes a kind of, in some ways, when this argument comes from mental health clinicians, it becomes a kind of psychiatry versus psychology turf war, where they say that, oh, if you give them a diagnosis or if you give them medication, you're pathologizing them. But hey, if they come to psychotherapy and they see me for psychotherapy, that's fine. I'm not pathologizing them. I'm just giving them, So and some of that, gets ridiculous in its own way too. And I think, we need to be mindful of those kinds of
Yeah,
dynamics.
absolutely. And I think what as an inpatient psychiatrist, I have fair amount of experience in even neurointervention. What neuromodulation? What I feel is that if someone really has worked on an inpatient unit, they have actually seen the presentation like what we see, a person who is floridly manic, no drugs involved, a person who is floridly psychotic, depressed to a point where they are catatonic, unable to perform basic areas of the life. I think that when people like me and you, when we clinically work and we see those things, and then we hear that argument, sometimes it makes me think that people making those arguments, a lot of them are actually either not clinical psychiatrists or even psychologists to that extent, and most of them have never actually set foot in that environment. So that is something that I always talk about. That once you actually see someone who's floridly manic without any drugs involved, how can you say that it is just a normal happiness?
Yeah, I think many of them have not had the kind of clinical experience that psychiatrists and psychologists and social workers working in many aspects of psychiatry do. It's not universally true. Sometimes we do see other clinicians making that kind of argument as well. But I think what happens in those cases is that I think their clinical experience is more I think circumscribed or limited in particular ways. They are they may be involved in some capacity, but they're not the ones taking responsibility and ownership of that clinical decision making. You know, and I think I'm always kind of surprised by kind of ability of humans to engage in motivated reasoning and confirmation bias. Some people just have such a strong ideological view that kind of that all extremes of human behavior are essentially just quote unquote normal phenomena or adaptive phenomena, that they just they can see the most florid delusions, and they try to explain that away. They try to explain that as just some versions of understandable commonsensical responses. So there's a lot of, I think, motivated reasoning involved too. But at the end of the day, I think if you have a person, I think, who is, let's say, floridly manic or floridly psychotic to a point that they cannot function in the community, there's a difference between clinicians who have the responsibility, who have to decide how to manage that and how to help that person and how to kind of help their family, versus a person who has no skin in the game and all they're doing is offering some kind of conceptual commentary or some kind of critical commentary, and they can say what they want, but as long as they don't take ownership of the problem, they're not going to be able to understand it in the same kind of way. And I think we should. I think if there are people out there who think that they can treat mania and acute psychosis better than psychiatrists can, or better than inpatient psychologists, social workers, open your treatment centers, show us, do the clinical trials, show us that what you can
Absolutely.
do. Take
Absolutely.
responsibility of that. Yeah, take responsibility of clinical care and show us that you can do better. And
Absolutely. I wanted to ask about your book, Conversations in Critical Psychiatry. Tell us a little bit about that because it's different than your day-to-day psych books or even psychology books. Tell us a little bit about your inspiration, motivation behind that, brief summary of what actually it is about.
Yeah, it emerged as it's essentially the book published by Oxford University Press. It came out late last year. It's an adaptation of an interview series that I had been doing for Psychiatric Times, before. So from about approximately 2019 to 2022, I was doing that series for Psychiatric Times, and what I was doing was that I was reaching out to various prominent kind of critics and commentators who had written about various scientific and philosophical debates and criticisms in the fields. And I was looking both for insiders, so psychiatrists who had offered critiques of psychiatry, as well as other academics and kind of other folks. And so fortunately that series had kind of gone well and was kind of well received and well read. And I think many people were using some of those interviews as part of their educational curriculum and assignments too. So there was value in bringing them together. So what we did was that we took a selection of those interviews, about 2/3 of them that had been published, and we kind of edited and updated them where necessary, and brought them together, added a few new interviews. And I wrote a detailed introductory chapter called Psychiatry and the Critical Landscape, in which I basically presented my own thoughts on how I make sense of this landscape of psychiatric critique, and what are some of the common themes, and especially what are some of the ways in which my understanding and my views differ from the kind of standard critical psychiatry narrative in that emerged from the UK, from the critical psychiatry narrative. So, and it covers, the book covers a wide range of voices. So, the first interviewee that I had in the series was Alan Francis, who you have had as a guest too. His book Saving Normal was a big influence on me during my training. And I did my geriatric psychiatry fellowship in San Diego, and Alan Francis is in San Diego as well. So it was just kind of a happy coincidence that we met. So he was the first interview in 2019. This was followed by Anne Harrington, who was a historian at Harvard, and her book Mind Fixers had just kind of come out and was influential. So, there's also Nasir Remy. We have Kenneth Kendler, who's done very important work in psychiatric genetics and philosophy of psychiatry. We have Peter Zakar, kind of Nev Jones, who has been kind of done some wonderful work in phenomenology and service research. Robert Chapman kind of work on neurodiversity and kind of other ways of understanding. So psychoanalysis, for example, Jonathan Shedler. So it's a kind of a diverse kind of group of people offering critiques of psychiatry, both insiders, outsiders from different perspectives, and also some of the prominent voices from the critical psychiatry network. So Joanna Moncrieff, Duncan Dougal, Sami Tamimi, they're there too. So I think the book offers a useful and accessible introduction to someone who is wondering what's all this fuss about psychiatry, what's going on, what's with all the debates and criticisms. And I think the book offers a useful starting point and an accessible map to these debates.
Okay. And you have also talked a lot about a few things. So overdiagnosis, you recently wrote about overdiagnosis. And then you have also talked about especially the biases in public in terms of in eyes of psychiatrists, like about diagnoses like borderline personality disorder. So can you tell us a little bit about that how to maybe as a psychiatrist, as a trainee, how to not fall in trap of overdiagnosis and how to fight your inner bias regarding some diagnosis?
These are some of the posts that you're referring to from my Substack blog and newsletter, Psychiatry at the Margins, and I've been working on that newsletter for 2.5 years now, and on a pretty regular basis, and again, kind of like the goal of the newsletter has been exploring these conceptual and scientific debates, and as I mentioned, I feel that a lot of public discussions and controversies around psychiatry result from a kind of conceptual confusion about what is going on. So in the recent overdiagnosis post that you mentioned, I'm doing a similar kind of thing where I'm saying that, hey, everyone is talking about overdiagnosis, but they're doing so in this really muddled and confused manner, and no one has any clarity on, well, what exactly does the overdiagnosis mean, but with what reference and kind of what, in what manner. So I unpack a dozen different ways in which people use and understand that term. And I talk about how kind of overdiagnosis, strictly speaking, emerged as a term in the context of cancer screening. In the kind of 1980s and the 1990s, it became obvious that some of the tumors that we were identifying through screening, some of the prostate cancers and thyroid cancers, they were basically kind of slow growing enough that they were only coming to attention because we were screening for them, and that if they had been left to their own kind of natural course, they would not have come to clinical attention. They would not have caused problems, and they didn't pose a fatal risk to the individual. So there was this idea that, oh, we are overdiagnosing certain types of cancers, and because we are screening for them, and treating them doesn't really improve the mortality outcomes. And so I think that's where the idea of overdiagnosis came. And I think it doesn't apply very well to the psychiatric context, because we're not aggressively screening in the same kind of way. Now, I think we do screen for depression, for example, depression and sometimes anxiety in the primary care setting, but that's about it. And even there, I think most people who are getting a diagnosis tend to be people who do have a problem. They are suffering. They do have symptoms. So I think in psychiatry, we don't really have a problem of people who are asymptomatic or who are not suffering in some manner being given a clinical diagnosis, right? So I think, the scope of, so it does happen to a certain extent, but it's not an epidemic in the same kind of way. I think the other meaning of overdiagnosis, I think, is that there's a lot of, what we mean by overdiagnosis is misdiagnosis, that the person is being given a wrong diagnosis, that a person, for example, doesn't meet criteria for bipolar disorder, but they are being given the diagnosis bipolar disorder, that a person doesn't meet criteria for ADHD, but they're being given kind of like, an ADHD. So we have to be clear about the overdiagnosis versus misdiagnosis thing, because again, there are different considerations. And this is where I think, there are issues of reliability in psychiatric diagnosis. Different providers don't agree on the same thing. I may see one person and I may think that kind of, this person has generalized anxiety disorder or depression with anxious distress. And another person may see them and they think, oh, this person has bipolar too. Right. And so these problems of reliability are well documented in the DSM field trials, like with low reliability of major depression and generalized anxiety. So how to navigate some of those disagreements, is we have to contextualize it, kind of the fact that, many times there are issues of reliability. The second thing we have to recognize is that sometimes there are sub-threshold symptoms. So maybe a person does have attention, concentration, and focus problems. They don't quite meet the exact DSM-ICD criteria for ADHD, but they do have problems. Or let's say a person is depressed. They don't meet the major depression level of criteria, but they have low mood or anhedonia of some form, and they're right. And so in those cases, that's again, I think a diagnosis of sub-threshold symptoms which are causing impairment is not quite the same thing as a misdiagnosis either, in which you're giving them a completely different kind of thing. And then some people kind of like, by overdiagnosis mean things like overtreatment. For example, people would say that depression is being overdiagnosed. And what they mean is that too many people are being given antidepressants or too many people are being given SSRIs. And again, that's a confused way of talking about these things, because overtreatment using a specific modality is a very different thing than saying that a diagnostic label is being, over applied. And I think the debate takes an additional kind of significance because there's a lot of self-diagnosis happening too these days. So a lot of people in the community they think that they have autism, but a clinician hasn't told them. They just they have decided themselves that they have autism. Or people they read about things and they watch TikTok videos and they think they have ADHD, but they have not kind of sought clinical care for them. They haven't gotten a clinical diagnosis. And I think so. Some people, when some people talk about overdiagnosis, they're talking about self-diagnosis. And again, self-diagnosis brings up certain distinctive considerations too. Sometimes when people self-diagnose, that's genuine. They actually do have impairment and they do have symptoms. But other times when people self-diagnose, they're confused or mistaken about what is going on. So I think we have to be clear about these different meanings of
Absolutely.
overdiagnosis and treat the conditions differently.
Okay. I will try to wrap up. So I'll ask my second last question. So my second last question is that a lot of psychiatry interns will be starting in a few days their residencies. What would be your suggestions and recommendations for them? Of course, they are new into the field. They will be starting. What are some things that they should be considerate about, or some generalized approaches that they should definitely consider following?
Yeah. So I think my general kind of recommendation would be, one, I think be very mindful of the kind of hidden assumptions and judgments that are guiding clinical work. So there's this framework that I talk about called conceptual competence, that just as we expect clinicians to be, clinically competent, and we expect them to be culturally competent and structurally competent, we should also expect a certain minimum of conceptual competence as well, in being able to articulate kind of, what are the assumptions and kind of other kind of related considerations. So I have there's a series of published papers on kind of conceptual competence and in different elements of that in psychiatric education that I would encourage, folks to look into. Another thing is that I would encourage new training, especially, to keep in mind is that there's a discordance between psychiatry as it exists in the textbook and psychiatry as we see in clinical practice. And as I don't mistake the textbook descriptions for kind of what happened, what we see in the clinic, and how we navigate that. I think people pick it up as they go during their training, but sometimes it can be disorienting and dizzying to realize, because everything looks so neat and structured and packaged in the
Yeah,
textbook. But when you're dealing with an actual patient, the problems are so fuzzy and fluid and
exactly.
kind of all
And
over the
and that's
place.
what,
And
yeah, that's what kind of happened to me when I started my residency. For schizophrenia, the textbook would be that someone would be thoroughly psychotic, having active hallucinations and agitation. But I think that what we in text we don't talk enough about is basically you see a patient 20, 25 years into their journey of schizophrenia, you may just see the disorganization. So first time when I encountered that person was not thoroughly psychotic and they were not responding to internal stimulus, I asked my attending, "Are you sure he has schizophrenia?" So I think that is very important that
yeah.
you hit the bullseye that the difference between the textbook description and the real life psychiatric presentations are different. There is a lot of gray area that residents will be seeing, where in the textbook it's a lot about more black and white and concrete things. I think
Yeah.
that's one of the biggest thing that the interns that are going to start their residency should focus on.
Yeah, I agree. And I would say that, take patients seriously, listen to what their experience is and what
Yeah.
they have to say. And if there's a contradiction between, the experiences of a patient and, what you think you have read in a textbook, the odds are that what the patient is telling you is kind of, is the real story. And,
Mhm.
there are gaps in our existing knowledge. So I think, taking patients seriously, and I think being mindful of the kind of popular narratives that exist, but are on scientifically shaky ground. So things like chemical imbalance and trauma narratives, and other every age has certain fads and certain trends that are popular kind of in the media. So I think being having a certain skeptical approach towards that. And I think I encourage I think trainees to read widely. One of my
Mhm.
complaints, I think, is that uh, trainees don't read textbooks anymore. It's kind of gone out of fashion. They'll read sporadic journal articles here and there. They'll attend their didactics, but the idea that you kind of read a textbook in a comprehensive kind of manner, that has gone out of fashion, and I feel like something has been lost because if you don't do that, you're gonna leave with gaps in your knowledge, and you're not gonna know what you don't know. So I would
Absolutely.
encourage people to kind of just pick a textbook you like, but
Mhm.
kind of read it in a comprehensive manner,
Absolutely.
and use that as a foundation.
So my last question, especially it would be for the viewers that uh, are we expecting a new book, any future venture for you from Dr. Awais Aftab?
So yeah, so it's actually just a few weeks ago, I finalized an agreement with Harvard University Press to write a trade book for general audiences. It's called Remaking Psychiatry, and the goal is to kind of unpack some of these shifts in psychiatric diagnosis and our scientific understanding of mental illness that have taken place in the 21st century. So kind of a lot of the old, I think, 20th century, idea of mental disorders as discrete disease entities, science has not been kind to that. And kind of what we have now is kind of much more dimensional. We are seeing a dimensional understanding of mental health problems. We are looking at mental health problems from a complex systems perspective. And the kind of old categorical way of thinking is dissolving, at least from a scientific standpoint. So the goal of the book is try to explain to the general readers, to the public, what this scientific shift consists of, and how that influences how we think about mental illnesses and how we think about mental health problems. So that's a project, and I'm excited about. And as I mentioned, I continue to work and write on my Substack newsletter,
Mhm.
Psychiatry at the Margins. And so, expect, more stuff on that newsletter as well.
And I must say that the educational content, that too specifically the psychiatric I cannot even imagine how many people love your content that you have more than 14,000 subscribers, because it's such a dry topic. Usually, even if you talk about it, you upload a video, you don't get that much audience. But that's what, and I would recommend everyone who listen to this that at least go to the website, because I think there are also you can read a lot of that stuff, at least some of that stuff without paying. So I think the kind of, and then Dr. Aftab sometimes shares some of that stuff on his Twitter, LinkedIn. So I would recommend everyone that pick up a topic, pick up an article and read about it, because what I love about your writing is the way you write stuff. Because we have all known a lot of people have a lot of knowledge, but it's the way you phrase it, it's the way you present it is significantly different than a lot of people. I and a lot of people have, most people have read. So that is something that I love about your writings. Thanks a lot, Dr. Awais Aftab, for giving us this time. I know that between your books, your academic work, your clinical work, you don't have time. I really appreciate you doing it, and I would request in future as well to definitely have you again in one of my podcasts and talk more about these things.
Of course, yeah, I'll be happy to join again in the future. And again, thank you so much for your kind comments about the blog and about my writings, Dr. Khan.
Absolutely.
I appreciate that.